Okay, greetings. How is everyone? Welcome to this class. And today we want to look at childhood and adolescence disorders. Before we begin, let me do our usual thing. As we do in Daystar, we always pray before we begin our classes. Shall we pray? Father, we thank you and we worship you. We thank you for the far you brought us. We thank you for the free gift of life. We thank you for this session that we're going to learn. We pray that, Lord, your knowledge come from you, that we may impact on others positively. Father, we thank you because you are a wonderful God and you've given us good health. Even these times of COVID-19, we pray that, Lord, you will protect us from any disease, any calamity. It shall not be near any of our tents, shall not be near any of our family members, our friends, our country, and the global impact that it's having on everybody, Father. We pray that, Jesus, you're going to surround us with blood, and that as we learn, oh God, give us a sense of peace and calm, that all is well because you say we shall not fear, Lord. Thank you for everything. May you bless us and be with us. In Jesus' name we do believe and pray. Amen. Okay, so welcome. Again, I want to welcome you. I know you seated in your house or wherever you are just to be able to learn today. And as usual, we usually catch up with everybody, know how you're doing and how everything is around you. But today we won't do this. However, I want us to believe everyone is doing well. Chris, how are you? Ali? Everything around you, are you doing well? Nancy, you're feeling much better? I hope so. Purity, I hope you're enjoying your new stage of life in marriage. Salome, how is everything down there as you work? Please make sure that our network is stable. And Mary, I'm sure you're missing your family being here as an international student. I hope they are fine and they're safe. Rehab, please make sure you're connected and not disconnected. Doris, how are you? How is your family here in Kenya and out there? Florence, please make sure that the security is around us and everybody's complying. So guys, good to know you're doing well, and if anything is not doing well with you, please, you're free to write me and send me an email or call me. You have my number and we can always catch up. Oh, so please, just before we go on, make sure you're keeping your hygiene routine. Keep it to the latter. I know we have a tendency of starting something and then along the way we drop it off. Make it a habit. Social distance, we've been told no. If you know you have symptoms, make sure you have your mask on so that you can protect others. Make sure your hands are always clean for everybody. And of course, just be everybody's keeper, and let's keep praying and trusting God that all will be fine, because I really miss to see each of you. So thank you so much. And today we definitely want to look at, as I said, child and adolescent disorders. And before we look at these disorders, I would like us just to make a recap of what we learned last week. Do you all remember? I noticed some of us were not in class. I don't know what really happened, but I hope whatever happened was not really anything that is bad. So I'm hoping that when we resume classes, we'll be able to catch up. But again, as I said, you have my contact. You can always call me, and we can always get to know each other. So last week we were looking, for those who are not in class, and even for those who are in class, we're just making up a recap. I wish we were all in class so that everybody can contribute. But last week we were looking at trauma and stress-related disorders. And basically we looked at these disorders in the sense that they are either caused by trauma or they're stress-related. And we said that last week when we talk about trauma, we look at an exposure to something that is very threatening. And this could, of course, impact the way someone functions in their life. And we mainly looked at PTSD, which we said last week that in the DSM-5 criteria, there are several issues that you need to look at as you assess your client. You know, have they been exposed to something that is threatening, or witnessed something that is threatening, or not necessarily witnessing, not necessarily being a victim of the threat, but they could also even have had, just like even watching on media, you know, someone causing harm that could cause you trauma. So we said there's that criteria. And of course, we looked at other areas in terms of, for example, you know, the hyperarousal of the body when you have a memory of this kind of a traumatic event. And we also talk about like nightmares that you experience. We also talked about avoidance. For example, if it was an accident and you're passing around that place, then you avoid that place. So basically, we looked at the criteria for diagnosis. And I keep insisting that you need to always ensure you get it right. And you can only get it right if you do good clinical intake. Make sure that the client has given you as enough information as possible. If you feel there's information that the client is not giving you, but it's directing you to a given disorder, try and ask the client, what about that? I also mentioned that when we're looking at PTSD, we look at the timing. Because I said disorders are also measured in terms of the time. For example, PTSD is when we experience these symptoms that we talked about last week, and they are after 1 month, they're still persisting, then that's what we call PTSD. And these symptoms could be there up to even about 6 months without anybody showing them, and they could come along the way even after 3 months after the exposure to the traumatic event or this. But most important is that they are experiencing this after a month of in the exposure of, they've been experiencing this for 1 month or above 1 month after exposure to this traumatic event. So basically, that's what we were looking at. We also looked at acute stress disorder and looked at some of the symptoms that entails that. And we also looked at the timing. Usually, these are symptoms that are presented before 1 month. We also looked at, they are presented in an individual exposed to a stress-related event that is usually below, the symptoms are there for almost a month or so. We looked at adjustment, and the main thing about adjustment is basically that somebody is adjusting into a situation, maybe life event, maybe something traumatic, or whatever that has happened, like a loss and grief. So basically, this adjustment disorder, they arise because of the adjustments. So now, we now want to look at, just to wind up, I'm doing this because you need to catch up with your notes, but we also looked at symptoms across all these disorders. We also looked at, causes of these disorders. We looked at effects of these disorders. We looked at some of the way we can treat these disorders. So I am hoping that those who missed class, please catch up with the rest of your colleagues so that you can know what happened and where we started and ended. So today we want to look at childhood disorders. And as you can see in the outline, we're going to look at various disorders. We'll look at disruptive disorders, and main two disruptive disorders we're going to look at are going to be oppositional defiant disorders and conduct disorders. Then we'll look at tics. I know we are conversant with this, but we're going to share more about it. We're also looking at attention deficit hyperactive disorder, and we'll also look at elimination disorders. And the two main ones we're going to look at in this class are going to be enuresis and encopresis. We'll also look at sleep disorders, and we'll look at sleepwalking and night terror. I want us to see what are we going to achieve out of this learning. By the end of this presentation or this class, we should be able to understand what are these child and adolescent psychopathology. We should be able to know the difficulties that are involved in diagnosis of child and psychological problems, understand disruptive behaviors and elimination disorders, and be able to also to understand childhood and anxiety and depression. Look at the symptom based on these disorders and of course differentiate. But the main goal is actually how this knowledge is going to be now used in your practical perspective. Because most important is how do we go about and diagnose these conditions and then treat. So you need to be conversant. And I keep insisting that at the moment the DSM-5 is one of the main inference book that we need to have, all of us. So as we look at them, we can use the criteria given in the DSM-5 to be able to diagnose. Remember, we said there are so many things that involve, before you make a diagnosis, there are so many steps that are involved. One, we always ensure that you take a very thorough clinical intake. A very thorough clinical intake is important because it's going to help you get the symptoms, get to know how long the symptoms have been there, get to know other factors that have been involved, know the patterns of these symptoms, know some of the perpetuating factors of these symptoms, understand probably the perpetuating factors, the protective factors, the patterns of these factors, the precipitating factors, and even probably the insight and many things that are involved in the class issues regarding these issues. So it's important that you ensure you take a very, very thorough clinical intake so that you understand this. Remember, we say the basic assessment tool that you can ever have. In itself is not just a clinical intake, but it's also an assessment tool. So even as you carry out tests, you're carrying out tests based on what you know, not what you don't know. So you just don't give clients tests. You're going to test them based on what you know. And these symptoms are the ones going to lead you to know what kind of a tool to pick, what kind of a tool to give to a client, and how to go about it. So maybe it would be important for me to introduce what child psychopathology is. Remember, when we talk about child psychopathology, we're encompassing both adolescents and children. And when we talk about child psychopathology, we just mean a scientific study of mental disorders in children and adolescents. That's exactly what we mean. So we are trying to study mental disorders in children and adolescents. You know, so many disorders exist in childhood, but sometimes they go unnoticed, sometimes they go undiagnosed, and therefore they actually end up affecting a lot of individuals in their adulthood. And sometimes they occur with others. Some of them are chronic, and of course they affect children in one way or the other. Now, a lot of times we say that these disorders show significant, what we call homotypic and heterotypic continuity later in adult as they grow up. And therefore, it's important to understand these disorders so that we can understand the treatment strategies and know how to deal with these disorders. Looking backward from adulthood, some researchers have actually found that many of the adult disorders are actually developed during the childhood. And that's what I'm saying, that if we can mitigate this, it will be very, very helpful, because then we will prevent or will mitigate what would occur when these children or adolescents later on become and so I had to mention that there are three main disruptive disorders. We have ADHD, or attention hyperactive disorder. We have opposite defiant disorder, and of course we have conduct disorder. Let's begin with ADHD. The main core features of ADHD usually is hyperactivity. We have inattentiveness, and of course impulsivity. And research shows that the prevalence of this disorder is between 6 to 8% among youth and children, and of course 4% in adulthood. What means that even as it begins, as much as it begins in childhood, most of these children end up most of the time being treated, and as they get the adulthood, you can see that this percent is actually going down. Now, for ADHD, usually the onset is before age 7, and you can only say that someone has ADHD if at least this behavior is present in more than one setting. So one setting means, like for example, this child presents with this hyperactivity or inattention or impulsivity in school as well as at home, or at home, in school, or somewhere else. So at least more than one setting. So you cannot say that the child is hyperactive or showing inattention or showing impulsivity in one social setting, and then you say the child has ADHD. No, it actually has to be more than one setting. One of the another criteria for you to consider when diagnosing ADHD is that usually it has to cause functional impairment in that child. So basically the child is not able to function well, and that's why you find most of these children will always have problems in school, will always have problems at home. Sometimes they are suspended, sometimes neighbors don't want them because of this. So it will all cause, and when you say impairment, for example, a child cannot be able to now learn well because of this behavior. Maybe because they're suspended or they are punished, and therefore causes the child. When we talk about ADHD, we mean that it's a group of behavioral symptoms which will include, as we said earlier, inattentiveness, hyperactivity, and impulsiveness. There are different types of ADHD. We can have a child who is predominantly hyperactive and impulsive in the presentation of ADHD. So they are very hyper and very impulsive. In other words, these are children who are very hyper, and they always feel like they have to be on move constantly. You know, they are all over. They will be under the bed, they will be running to touch this, they will be running to touch ABCD. So basically they are all over. We have another type of ADHD which is predominantly inattentive, meaning that they can never concentrate for a long period of time. They have a very short span of concentration, and it means that they have difficulty paying attention, they are easily distracted, and they might not necessarily be hyperactive, they might not necessarily be all over, but the problem is that they are not able to be attentive to whatever they are doing. Then finally, we have the one that has combined presentation. So basically, you find that this is a child who is hyperactive, and they are always on move, and they don't even pay attention for a long period of time. So you can have that and that. Now, if you look at that diagram there, so you can see the most common type of ADHD is the one that is predominantly hyperactive and impulsive. You can see that's 50 to 75%. That is means that it's the most common one. Then the next one is the one that is inattentive. Very few people have this combined type. So you have very few people with very combined type. Now, or children, I keep saying people. Now, what do we mean predominantly inattentive? It means that these children are usually easily distracted. They are not excessively hyperactive. They are not always on move, but they are easily distracted. And we can see it's not the main one, but it's after the main subtype. The one that is very commonly diagnosed is the one that is hyperactive and impulsive. So you find that these kids are extremely hyperactive and they are all over. Inattentiveness is not a big deal, but it doesn't mean they can lack it, but it's not as high as being extremely hyperactive or impulsive. And then finally, we have the ones that are combined. So they have various combination of all the two that we have already discussed. When making a diagnosis of ADHD, what is that you expect it to do? One, remember that ADHD is a clinical diagnosis. Make sure you do a very thorough clinical intake. And this intake is collateral, where we mean that you're not just getting from the child alone or the parent alone. Remember that this is a child whose we've said that they have these symptoms in at least 2 setups. So it means that a setup like the school, you might have to get some history, and also part of the tools that you're going to give out, you have to give to the teachers. And of course, we say that you must do a thorough assessment and make sure that the tools that you're using are correctly for ADHD. Always establish if there's any comorbids, and we say that sometimes this condition comes with various comorbids, so it's important to also ascertain that, and of course rule out medical conditions. And this is something we've already emphasized in most of our classes, that you must always rule out medical conditions, because if then the medical condition is the one that is predominant, then it means that we have first of all to have this client treated, and then now we can see how best we can help the client through these other conditions. In terms of, for school children, usually with ADHD, you find that they're easily distracted in class. Something small, like the noise you've had, they will be standing up to see what is it happening, easily distracted. You look at their homework is very poorly organized and very careless. They have a lot of errors. Sorry for that noise. Sorry for that noise. We have some staff who are pulling out some chairs. But what we are saying that usually for school children, very easily distracted. So you find that they are unable to withstand anything that distracts. Just even something very little, just even a paper falling down, they'll be distracted. Their homework is poorly organized and very careless. Sometimes they don't even complete their work or even lose it. And then we ask, where did you put it, John? Where is it? And they're like, maybe I don't know. And even they don't even have time to look for it. Sometimes you find that most of them will have low academic scores, and the reason is because they don't learn a lot. Because of the distraction and because of unable to pay attention a lot, you find that they get low academic grades because of that. You find that a lot of time they will be frequenting to the principal's office because of mistakes. You know, some teachers even don't understand this kind of a condition. And if they don't understand, some of them are intolerant and unable to tolerate some of these children. They will blast out answers even before question. As Monique, the teacher is asking, okay, Mary and John, and they say, oh, they went. They just blasted an answer, even before waiting for the question to be completed. And this sometimes disrupts the class because, see, if you can blast out a question even before the teacher says it, it means that then others couldn't even get the question. You'll always find that most of the time they interrupt and intrude on others because, you know, being in one place is very distractive. So they go to other kids, move, pick some things, do something, because they don't want to be, you know, they can't stay cool for a long period of time. Some of them display aggression, maybe because they're fighting back, because of what others are doing to them, those who don't understand them, sometimes because of the punishments that have been going through for various reasons. So they also become aggressive. These kids have very poor peer relationships because they always distract others, and for that reason they have poor peer relationships. Very rarely do they wait to take a turn. For example, when they're playing with others, they may not be able to take a turn. And some people think that this child is so immature, is behaving like they are not of their age. So people have no patience with them. And of course, sometimes when you give them homework, they're unable to complete, and they are accidents. For adolescents, other than some of the things that we've already mentioned in children, they may have a sense of inner restlessness rather than hyperactivity. In other words, they are just wishing to move out, to go out, to do something. So their inner restlessness is disturbed. They procrastinate a lot and display very disorganized work, just like the other kids, the children, the smaller ones, because they want to finish quickly and do something else. Working independently is difficult because even if they work alone, they can't complete the assignments, they don't do it very well. Poor self-esteem, especially because of what happens, the repercussions they have after they portray this behavior. Sometimes teachers punish them, their fellow friends may not say very good words to them. Most of them are poor peer relationship, you know. You don't want someone who's distracting you around. You don't want someone who is not paying attention. You don't want, so most of them don't keep relationships. And of course, they can't delay gratification. For example, you know, they're supposed to go for something like for a break, for tea. They want to quickly move out. Some of them may have experienced learning disabilities. Some of them, whether you punish them or not, they will still just behave the same way. They could engage in risky behaviors, and of course, safety. Most of the time, they also get into accidents, and they also clash with authority like teachers, like parents, etc. So basically, these are some of the areas you could check when you're doing your diagnosis, or you're doing a clinical intake, before you make a diagnosis. Make sure you look at some of these. Before school, what happens, school time, how do they function, after school, and bedtime. Let me not go through because you'll have time to go through, but basically look at these domains. As you do your assessment or your clinical intake, you look at these domains, how do they function before school. For example, they don't want to wake up in the morning, they're really feeling they don't want to go to school. And one of the main is because school, nobody's giving them attention, nobody is giving them time, so they will always be punished. So school is never motivation because school is good. At school, you hear they have low grades, they always disrupt other people and friends, and that's why they don't want to go to school in the morning. Because these are children who are going to have a lot of problems with the school authority. After school, you hear most of the time they engage, probably got accidents, etc. Bedtime, it's so difficult for them to settle down and go sleep. So you could use this table to help you to assess these domains so that you can be sure that you are actually dealing with ADHD. My point here is, I don't know whether my slide is there. My point is, when you start picking this, when you do the history and start picking these symptoms, you could just ask the parent or whoever's got in the child some of these areas. You want just to be sure you're dealing with ADHD. You want to be sure that your direction of your taking is actually taking through ADHD. Then some of the symptoms of impulsivity is that they are always impatient and there's trouble waiting for it. Like, for example, okay, can you queue up for your snack? She's number 3. She can't wait. She wants to go and be the first one to pick up the snack. As you said earlier, they blast out answers. Your teacher is asking, okay, John or Mary, let's say that she's Mary, and you're asking John, what do you think we should do to keep our hands clean? I think we should be, so Mary just blast out, we should go to get water, you know. Before even her turn gets, you are directing the question to John, and now she jumps in. And then, of course, they react over their feelings and emotional situations. They can cry loudly, and they don't care about the consequences of their actions, even if they have been punished several times or disciplined or reinforced. Hyperactivity, they just like talking. They move nonstop. They can be from one place to another, frequently. They like fidgeting and picking up everything. And of course, they even have trouble sitting down just to cool down for anything like a meal or a quiet activity like praying. You're praying, and before you say, they're already saying amen because they want you to finish up quickly. Now, these kids struggle to cope. Quite tough, yeah? Struggle to cope, and a lot of people don't understand ADHD. A lot of people will label it as poor parenting. A lot of people will label it as immaturity. But these children are really struggling. And use a psychologist, use a counselor. You can understand why this can be a really, really big issue to this kind of a child. And you can understand why we are saying some of them can't even get good grades. Not because they're brilliant. Children could be with very high intelligence or IQs. But because of the situations which they go through, how people perceive them and take them, then they are unable to learn well and, of course, score the way they would like to score. But some of the comorbidities that could come with ADHD could be learning disabilities, like, for example, what we call social communication disorders, which makes a child to have a difficulty in conversation socially. Auditory processing disorders, a child is unable to understand and follow spoken directions. Motor or oral tic disorders, for example, the Tourette syndrome, amongst others. And of course, they could also develop ODD or CD. And for reason is just because of the way we treat them, and they want to create some kind of a mechanism, or they want to create something like a defense over themselves, so they become defiant, they don't obey authority, and they could fight others, etc. They also could have a lot of problems with regulating their emotions, and this is because it's just one of the symptoms that come with it. The other area we want to look at is ODD, or Opposition Defiant Disorder. As we said, that this is simply from the word defiance, and according to the DSM-5, you know, it includes symptoms of negativistic, defiant, disobedient, and hostile behaviors towards authority figures. They defy anybody in authority. They defy anyone in authority. They don't give them listening to anyone in authority. And a lot of time they have a problem with figures of authority, like teachers, like parents, like prefects, etc., school captains, amongst others. Children with ODD usually they have tantrums. They are easily annoyed by others. They defy and refuse to comply with authority, like teachers and parents. Yet they know the rules. They understand what is there, but they just defy. Very argumentative with adults. Sometimes rude and uncooperative, and very confrontational attitude. And of course, they use mean language when they're upsetting others. They could just say, "Bad word, you are stupid, you're a fool." So they have this mean-spirited language. They like upsetting others because they annoy others, and with a lot of course, you know, "I'll take your pen and then you'll not take me anywhere." You hear such kind of statements. They burst out of anger. "Why did you take my pen? I'm going to beat you." That's kind of it. They blame others. "It's you. It's not me, teacher. It's her. It's her who did everything. It's not me." And they will say it with a very mean language. And of course, they have this outward and belligerent defiance and revengeful attitude. If one kid goes to report her to the teacher for fighting her, she will revenge it when they go home, for example, or in another different format. We also have conduct disorder. It's very closely related to ODD, and it's more extreme condition. By the way, for children, we call them ODD. When they now become into adolescence, we call it CD. Similar kind of portrayal of symptoms, but now the difference is the stage or the level of this disorder. So if they're children, we call this ODD. But when they're adolescents, we call it CD, or conduct disorder. I would say that these are children who are basically aggressive, deceitful, and destructive. They hardly listen to anybody. They hardly obey instructions. They hardly follow rules. They are defiant. They are basically, they like violating rules of others. You know, bullies in high schools. They are ever doing bad things to others, and especially in Kenya, we know there's a lot of bullying in high school. Most of these children are very bullies. You know the case of where a child in one of the schools in Kenya, they would take others to go and sleep on the graves of the founding fathers of those schools. Alternatively, they give them something like a shoe and tell them to call home, and they want money in the next few minutes. And you have to call. The shoe is it's like the mobile phone. You call your parent and tell them, you need, and therefore you're forced to move. The other child is the victim is forced to move, get some money from the pocket, and then give them. So basically, conduct disorder. And we're saying that they have a very aggressive behavior. For example, they intimidate and bully others. They physically harm others or animals. They just kick a cat, poof, with their foot. On purpose. They can even commit rape. They can use weapon. You know, deceitful include lying, breaking into somebody's box or breaking somebody's private property and entering and stealing. They can forge even signatures. Most of these kids, most of the schools we hear them ban in Kenya, a lot of these children have conduct disorder because they go and buy petrol, come and actually cause destruction of property, and they end up definitely, you know, having problems with the close with conduct disorder CD, include harsh punishment. You know, for Kenyans who are here, I don't know about Anne-Marie, I don't know about Doris in your country, but I know that in Kenya, we have the Bosso schools, which we call the institutional schools living. We used to call them approved schools, and the name has changed just because of the negative connotation that the name had as approved school, because it always looked like these are unbearable children. When your parent took you to an approved school, then even coming home in the society was unwelcome, even as much as you've changed. But some of these children end up with harsh punishments. Some of them end up in such kind of schools. Some of them will end up, of course, living with different relatives because you can't cope up with these kind of children. And some of them, you'll find that they engage, there's a lot of parental conflict, even poor parenting, monitoring. It can cause the parent into depression and the father also into alcoholism. If it is not if children, you don't assess for ADHD, you don't assess for defiant disorders, amongst others, disruptive disorders, you want also to check. Some kids present with tic disorders, and we want to see of course, they come in various forms. Probably let's begin with Tourette's disorder. Usually, a child will present with a multiple motor or one or more vocal tics lasting at least 1 year, many times a day, nearly every day, without a tic-free period of more than 3 consecutive months. Do we get that? Anne-Marie is looking at me. Anne-Marie. Tourette's disorder is simply, we're saying that a child can present with a multiple motor and 1 or more vocal tic lasting at least 1 year, many times a day, nearly every day, not every day, without a tic-free period of more than 3 consecutive months. In other words, what we are simply saying here is that a child will present with a multiple motor problem, for example, the way they walk, and then they have 1 more vocal tics, for example, or more than 1 vocal, so you can hear it. So you can, you know, that kind of a tic, and then, or it's like something is choking them. So they can have those 2, maybe with a limping, or the way they walk, or the way they use their hands, or the hand is shaking. And then, of course, we're saying that many times a day, not every day, but nearly every day. And of course, this has to be there for at least more than 3 consecutive months. The onset is before age 18. So usually the child, these tics and motor issues are there before age 18. It could begin at around between 5 to 8 years. By 8 and 11 years, it's very profound, and everybody can pick it. And actually, it could end, or it could go through into adolescence. More boys, as compared to girls, present with Tourette disorder. So some of the statistics are here, as we see. A lot of children with Tourette disorder, 40% will meet a criteria for OCD. That's what we're saying, you look for comorbids. 20% will also, with any tic disorder, will have OCD. And then, of course, you're saying 8 to 20% to 27% of children with Tourette disorder might also have ADHD. What is the point here? The point is here is that when you're assessing, do a thorough clinical assessment. Make sure you're checking out for these comorbids so that you can be able to know how best to help these children. Some of the way we recognize tics, I wish we were in class so that you guys can demonstrate. It could be brief clonic movements of the eyes, you know, blinking, the way we blink our eyes. Face, neck, you know how we do the neck? You keep putting it, you keep turning it left and right. Shoulders, Eye blinking is very common. Head jacking, some tics involve throat like clearing the throat or grunting. Some of them are simple, some of them are elaborate. I hope you can actually identify with this and probably around your setting, or alternatively even in your own experiences. And next time we meet in class, I would like us to try and demonstrate in class and give examples. Now, tics are not hair twirling, skin picking is not a tic, OCD is not a tic, a throat allergy is not a tic, sniffing is not a tic. So rule out these as tics. Most treatments of torrent, we have alpha agonists that we can use in terms of drugs, neuroleptics such as risperidone, nicotine patches, amongst others. But because we don't use more drugs, you could refer this for treatment of drugs, but then we continue therapy, sensitizing the person as well as the family. So if not, maybe you're dealing with an anxiety in a child. We've talked about so much about anxiety. I'll not go so much about it because we talked about anxiety disorders earlier on in one of our previous course lessons. But remember, we said some of the causes are genetic, environmental, temperamental, and of course, this could cause an anxiety in a child. So, child with anxiety and depression. For anxiety disorders, just as we said last time we were in class, basically it is compounded with nervousness and ease, and of course something that is futuristic, anxious about something that is futuristic. And an anxiety disorder, usually we talk about it as an internalizing behavior, and therefore, just like the other types of anxiety that we did talk, you want to make sure that the diagnosis fits within an anxiety disorder. We talked about various types, but we didn't mention about separation anxiety. And as the name suggests, it's just an intense fear of being separated from your primary caregiver, the person whom you're close to. For example, your parent or a carer. Most of the time, it will start at the end of the first year of a child. It could reduce along the time, but it's just a child is separated from a caregiver or a primary caregiver or a parent that they are close to. And this affects the child even when they go to school, because they will never be settled in school, because most of the time they want to be back that caregiver or the parent or the person. Usually occurs at around age 7 and 8 profoundly. You see it at around that age when the child is going to school. And sometimes theories have explained to say that this could be angry feelings towards parents. Sometimes I emphasize and say, look at an environment where there's domestic violence and maybe the mother is disadvantaged, and for that reason you find the child feels that they want to be back and be near their mother because they are fearing the worst that could happen to their mothers. So when they're in school, they're not very settled because they always want to go back home to check on their parent or be there with the parent. So teachers will complain and say the child was really sick when they were in school, but when they went back home, the mother says, well, I am shocked. When he came home, he was so fine. He didn't even look like he's sick. There was no sickness. So that could be actually separation. So they have this excessive worry concerning a separation from those to whom they are attached to. And this could be persistent excessive worry about losing them or losing the attachment figure. Persistent or excessive worry in the event that could lead to them getting disattached from that figure. Maybe the parent being kidnapped, or the parent has died, etc. And also persistent reluctant or refusal to go to school because their fear is they'll find this figure not available. So when you're looking at your diagnosis, is there worry? Yes. About what? About harm befalling my mother, about harm befalling my dad, etc. Is there a worry? Yes. About something that could make them lose their figure, their attachment figure? Yes. Maybe they can be kidnapped, or they get lost, or they die, etc. And of course, there's a school issue. They don't want to go to school because they think if they go to school, they'll find either one or two has happened to their attachment figure. Alternatively, if they go, then basically they will lose their attachment. Then, of course, you want also to look at relation to be alone. They don't like at night, they want to get sleep near their mother or with their mother, because as again, 1 and 2 might happen to them. Criteria A or criteria A and B might happen to them. So basically, they are reluctant to be alone without the attachment figure because of what could happen to their attachment figure. They don't want to go to sleep or because they want to be near this attachment figure. And when the parent sleeps away from home, that brings a lot of anxiety, and that could bring even depression. They have a lot of nightmares involving the theme of separation. They keep talking about, I dreamt my mother being kidnapped, I dreamt my mother not coming, I dreamt my mother, or I had. They don't talk about night, they just talk about dreams in terms of how they. Then they'll always complain about physical symptoms, like they say they have headaches, stomach aches, they are vomiting, and this happens in school, and that's the reason why the teacher will feel obliged to have the child go back home for medication or for physical examination, because they are really they are certain and they are sure that the child is sick. But believe you me not, parents will say that when the child came home, they just looked fine, they don't look sick. So you also want to look at if this disturbance is for at least 4 weeks, and the onset is before age 18, and this causes distress and impairment in social or academic functioning, then you correctly are diagnosing anxiety, separation anxiety. And even if you have to undertake the tools, they should lead you to this. So one of the main symptoms that you want to always look at is if they don't want to go to school. And basically, separation anxiety comes with depression, sometimes comes with depression. So you might want to assess for both, and also in treatment plan. You also want to think about the same in the event you are diagnosed for the comorbid. This slide and say that, the criteria that we have had for the depression remains the same. It's just the presentation of children and adolescents different. And since children even don't know how to talk about depression, it's important that these symptoms are picked up very well, either from the parent or the child or the adolescent, alternatively from your assessment through the art or play therapy. Make sure you pick them up very well. And if there are any gaps, you might want just to ask whoever's got the child so that you can fill up and assess correctly that you're sure this is actually depression. Elimination disorders, and mainly we said earlier in the beginning, we look at enuresis and encopresis. Enuresis is simply involuntary discharge to the bed or clothes, which we call bedwetting. So they discharge urine involuntary, and sometimes this causes, most important about a diagnosis, that if it is causing, if the child is not adjusting well, it's affecting the function of the child in several settings or even one settings, then you know that actually you're dealing with the disorder. So they pass urine during sleep, or sometimes even class, seated just passing urine, and there's a difference between the normal bedwetting of a child in terms of their age and developmental stage, and the one that you think this is actually a disorder. So basically you have to differentiate between the two. You make sure that if it's just a child who's 2 years, 3 years old, this could just be okay. 5 years old could be fine. But then when they're like now 8, 9, 10, 11, adolescents, and they're wetting their beds and discharging urine involuntarily, probably in class or any other place, you want to check on whether it's a psychological problem. So for enuresis, we talk about repeated voiding of urine into their bed or clothes, involuntary or intentionally, but they pass it. At least the person is above 5 years old. There is no physiological effect that is affecting this, maybe substance or etc., or someone has diabetes. So rule out any medical condition. In other words, just rule out any medical condition. And then, of course, usually you find these children have low self-esteem and it affects them. So I'm saying this problem affects them, whether in school, whether at home or anywhere else. It affects their functioning, and some of them will have low self-esteem. In fact, a lot of time they don't want to go to areas of social setups like schools, like functions like parties and etc. So you want to check out on that. Incorporates on the other side is simply they now involuntary, voluntary pass feces. We could call fecal soiling in children. Despite that they have gone through toilet training, they look stool into their clothes. And I want to give an example. I remember my cousin, even when he was in high school, he had incorporacies. He would just, lick stool into clothes. And I remember what he went through was really bad, because we used to beat him thoroughly. Because people just didn't understand, how can a 14-year-old person pass stool into their clothes? Nobody understand. How was he when he was 8, when he was 7, 9, 10, all the way through high school? And it was really a sad situation. It's just now I learned later that honestly, we were a little bit unfair to him. But I think he went through a lot of psychological, physical, and emotional torture just because of incorporacies. And I learned this much later. I definitely owe an apology to him. Sometimes people find this very frustrating, and they still believe the child is misbehaving, poor parenting, or immature or stupid. People will come up with very many names over this kind of a child. And they make them feel ashamed, make them feel very guilty, make them feel very frustrated and angry. And most of the time they want to hide. And some of them can even be suicidal. So basically I would say that it's one of the most kind of a disorder that brings a child's low esteem down very, very low, and the adolescents as well. And this could even affect their going to school. They can drop out of school, because see, who is going to tolerate a child who is, licking or passing stool in their clothes, yet they are supposed to be mature enough to take care of this. So you want to really assess and make sure that you get it right, and empathize with these children and try to show them love and care as you do all this. Basically, the whole of counseling is all about love, it's all about empathy, it's all about, modeling and showing that you are different from the other people who are outside there. So basically, try to ensure that you take this into consideration as you take care of the child. So this is what we call incorporacies with enuresis. So you can have both. A child can go with both. But in the DSM-5 says that there are two subtypes. There could be incorporacies with constipation and incorporacies without constipation. So with constipation and without constipation, not all of you understand constipation. So try to differentiate. In my own experience, you want also to check for any sexual abuse that this child has gone through. If there's any sexual abuse, a lot of children sexual abuse, boys who's been penetrated, girls sexual abuse, they could have enuresis and incorporacies. In my own experience, the one that I've handled, there's a sexual abuse history around it. So do a thorough check of the history and check for that. Okay, I had said initially, and finally we have somnambulism, which is we call sleepwalking. I experienced this case about 2 weeks ago or so. A child had been suspended from a school for sleepwalking, and my recommendation was just simply, how can a child control? These are very involuntary behavior, so how can the child control this? So sleepwalking occurs during the non-rapid eye movement, and of course during the slow wave movements. And some of the symptoms usually include sitting up in the bed, walking around the bed, leaving the house, falling out of the windows, attacking others, etc. Remember, these are very involuntary behavior. The child is asleep, doesn't know what is happening, so they wake up and start walking. And in my case, there's usually a history behind that. For example, in my case, when this child goes through any stress, they will always sleepwalk at night if they don't deal with the stress. So stress can actually trigger this. They don't do it so often, you'll find that. A lot of time they will have no memory of what happened, so this story will be told by others. If it's a school that is like a boarding school, they will be told by the matron or the housekeeper that you are walking in the night, or other kids. So usually they have no memory of what happened. Their eyes are open, but they are sleeping, remember. It can last as little as 30 seconds, but it even can go up to 30 minutes. And 30 minutes, a child would have done a lot of activities in the house or around the house, even going out of the house. So this kind of kids literally needs a lot of people, a lot of support in terms of someone else always to be ensured that they're in their room, so that in case of they open the door, go out, you can follow them and take them back, slowly back to sleep. They are asleep, so you can actually carry them back to sleep and back their beds. And that's very important. It decreases with age, and of course, we say that some of them also end up with enuresis. And it's something that something happened, and that's what I'm saying. Look for any stressor. Is there any stressor around this child? In my own experience, there's always a stressor around sleepwalking. So you'll always have to check for it if there is any. So I don't want to go to the stages of sleep, but we have said that it's actually around stage 3 to 4 where the child experiences sleepwalking, and therefore check for that. The main common treatments of now finally of psychotherapy, drug therapy, because we talk about ADHD, we're talking about some of the disruptive disorders and etc., depression here and etc. We can say that drug therapy works, but because you are not sure, when you find that, I always insist this, you know your competence. One, you're not supposed to give drugs. You only assess, and if you see this requires a drug, send them to psychiatrists who agree to give them, refer to psychiatrists to give them these kind of drugs. But you find that most of them, for example, depression, will be on drugs, like major depression, and then like ADHD, some of them on some extreme anxiety disorders will be on drugs. So basically drug therapy works. We also that helps, and we have behavioral therapies that can work, and some of family therapies do work. You include the family in terms of, always most of these treatment children therapies, you need family interventions, because most of it you want to educate the child, the family about the condition. You want to also get a support system for the child. You want to get a protective factor for the child. So basically they will involve family intervention. And of course, CBT also works, and as I told you, I need to take you through a structured CBT, which can help you deal with some of these conditions. But mostly you want to look at how they think vis-a-vis, how they behave, how they feel, and combine some of the CBT techniques to see how best to use in order to help them, like psychoeducation, reinforcement, role modeling, cognitive restructuring, confrontations, constructive confrontations, amongst many other CBT, systematic desensitization, among many other CBT techniques that you can actually use. We'll go through them in our course. Let on art therapy, which is very, very important. They draw, and part of the drawing helps them deal with emotions, but you also are able to help them, you're able to assess some of the conditions. So as we come to the end of the class, just want to ask you if you have any question, let me know, and you can write me. You can be able to ask any of the questions you want. And as we said, that these are just a few childhood and adolescent disorders, not that they are the only ones, but there are several. However, as we come to the end of this class, please feel free to ask any question. You have my email, you can call me anytime you want, and we can always help each other. remember to share with everybody. If you have any question among yourselves, that's a very good thing. Now, even as you ask me a question, I want to come to the end of this class. However, I just want to remind us, you have several assignments to submit. Remember, you had a movie assignment. Do you remember? Early? Yes, we have a movie assignment. Please, you just send me your report on the class e-learning platform or my email. That's okay. Secondly, you had a group paper to do. Please put together your work, share among yourself how you reach each other, put up your paper together and submit it. Then there was a paper to do. You are supposed to, each of you, write on any of the disorders we are learning in class. Please also will have to send them for grading. I'll give you directions on, in the course of the week regarding on when to submit each of that assignment. Just remind all of us, because I noticed that last week some of you are missing class. So I will definitely be able to ensure that you submit on the time that we had agreed. Is that okay? Any question? Chris, call me or send an email. Ali, please also send if you have any question. Nancy, Purity, Salome, Anne-Marie, Doris, Florence, all of you, if you have any question regarding child and adolescent psychopathology, please send me and then we'll be able to answer. Otherwise, I want to wish you well, keep safe, and we'll